مساء الخير على حضراتكم، شكرا جزيلا. Thank you for this invitation and good evening, everybody. We will talk about the osteoid osteoma, IR versus surgery. This was a systematic review that was published in July 2022, talking about the surgical management of osteoid osteoma. In this systematic review, it was stated that the success rate of percutaneous ablation is higher than that of open surgery in osteoid osteoma. However, open surgery and cryoablation can be selected for osteoid osteomas close to the nerve and atypical sites, while RF ablation or microwave ablation can be selected for osteoid osteomas in most other sites. So in this presentation, we will answer two questions. First of all, what are the atypical sites considered for osteoid osteoma and what are the typical sites? And is really RF ablation or microwave ablation not a preferred line of treatment for osteoid osteomas in these atypical sites compared to surgery or not? The usual locations of osteoid osteomas, as we all know, in the subcortical shaft and metaphyses of long bones. The tibia and femur account for more than 50% of cases. And the unusual and high-risk locations are considered in the intra or juxta-articular lesions, the spine, and the short bones of hands and feet. The articular osteoid osteomas account for 13% of cases, and they are mostly located in the hip. Less commonly, they are seen in the ankle, elbow, wrist, and knee. The spine osteoid osteomas account for 6% of cases, and they are mostly located in the posterior elements of the spine, in the lamina and the pedicle. So what are the risks of thermal ablation of osteoid osteomas in general, and especially in the atypical sites? We are always afraid of mechanical and thermal injury to the peripheral nerves, the skin and subcutaneous tissue, the spinal cord and nerve roots, tendons, vessels, and synovium in case of intra-articular lesions. When we talk about surgery, what are the risks of surgical excision of osteoid osteomas? We see many cases of incomplete or non-target excision, especially when there is an extensive overlying sclerosis. There is prolonged immobility and delayed recovery in surgery. Sometimes there is a need for bone grafting, fractures may happen, dislocation, and osteomyelitis, synovitis, or arthritis in case of intra-articular lesions. When we perform RF or microwave ablation of osteoid osteomas, we usually adopt the safest and shortest routes, and always safety comes first. In this case, for example, of osteoid osteoma located in the posterior aspect of the femur neck, we have three possible approaches to gain access to the lesion: this anterior oblique approach, this posterior oblique approach, and this straight posterior approach. We should put into consideration the site of the nerves, the vessels, the femoral vessels, and the shortest route, of course. So we use this posterior oblique approach, putting into consideration that we are away from the sciatic nerve. The sciatic nerve is not affected mechanically and not affected thermally. We put into consideration the active tip of the needle of RF or the power of microwave ablation to attain this small size of ablation, not affecting the sciatic nerve posteriorly. So the safety measures when we perform thermal ablation of osteoid osteomas: the patient positioning is considered an important safety measure, and it needs a lot of calculations when we work. We should put into considerations the vessels, nerves, tendons, even the structures that are at risk. The imaging guidance, the choice of RF and microwave needle concerning the active tip, the power, the duration of ablation. Sometimes we need to use hydrodissection or pneumodissection. Sometimes we need to use ice-cold packs on the patient's skin in case of the very superficial lesions, especially in the hands and feet. We will see these examples, and thermocouple may be used too. The RF needle, osteoid osteoma, is a benign tumor, not a malignant tumor. We do not have to ablate a safety margin around the lesion. We have only to ablate the lesion, which is by definition a small lesion that is maximum 1.5 centimeter in diameter. So the active tip of the RF needle is different from the active tip of the RF needle used for HCC, for example, or used for lung ablation. A small active tip usually is enough to ablate the whole lesion. Some RF needles are provided with a cursor that help us to control the length of the active tip of the needle according to the size of the tumor. Nowadays, microwave ablation is widely used for ablation of osteoid osteoma, and it has many advantages, as we can see. The needles are light and short needles in comparison to the old microwave needles. Of course, no ground pads are needed, no risk of burn. It's faster in comparison to RF ablation. It's not affected by tissue charring, and those who work in ablation of osteoid osteomas, they know very well what is the bad effect of tissue charring when they perform RF ablation of very small lesions with a small active tip of the RF needle. This is not the case in microwave ablation. Ablation size could be controlled per one needle, and the ablation size and shape. It has a uniform, predictable ablation shape, and it has a faster recovery in comparison to RF ablation. In this, for example, when we have an osteoid osteoma of 0.5 millimeter by 0.9 millimeter, and the most case of osteoid osteomas are elliptical in shape. They are not that typically rounded. By using microwave ablation of only 25 seconds and 25 watt, we can have this size and shape also of ablation. We can ablate this 0.5 by 0.9 millimeter in only 25 seconds, so it's very fast. Let's see some of our real-life cases. This case, for example, of an osteoid osteoma located in a very atypical and difficult position in the acetabulum. Let's imagine if surgery is done in this case, what would be the effects? And also, when thermal ablation is performed, we should put into consideration that the lesion is intra-articular. We have a synovium. We have a risk of joint effusion after the ablation, and we have the sciatic nerve located here. We put the patient in a prone position. This is a safety measure. We adopted this approach, this posterior oblique approach, away from the sciatic nerve, and we used a very small active tip of the RF needle, which was 7 millimeter, and this was only the ablated area. A very small area of the synovium is affected, so no joint effusion will happen, no arthritis will happen when we perform just 5 to 6 minutes of ablation with a very small active tip. So why not surgery in this case? Surgery may carry the risk of hip dislocation. Surgery may carry a risk of prolonged immobility and delayed recovery in comparison to RF ablation or microwave ablation, and it carries a higher risk of arthritis and synovitis. This was a case of osteoid osteoma in the plantar aspect of the proximal phalanx of the middle finger. The challenge was how to place the patient hand on the CT table and how to maintain a stable position of the RF needle into the nidus. So this was the final position, and we gained access to the nidus by a bone biopsy needle, and then we removed the bone biopsy needle and we reintroduced the RF needle in the same place, so the light-weighted RF needle will be maintained in a stable position within the nidus, and a 7 millimeter active tip was enough to perform a safe ablation. I found in the literature a picture of osteoid osteoma in the proximal phalanx of the ring finger and also one in the middle finger that was performed by surgery. Let's see what is the difference. This is a major surgery. This is a big surgery carrying a risk of big scar in the finger, loss of some of functions of the finger after surgery. So we can compare between thermal ablation, which was a procedure that was performed in less than an hour, in comparison to this major surgery in the finger, followed by a big scar, an ugly scar in the finger. This was a case of osteoid osteoma in L5. We have a risk here of nerve root injury and spinal canal injury. So by a safety measure, we should perform protection of the nerve roots and spinal canal using intra-epidural injection of dextrose and air to create a cushion, a protective cushion between the nerve root and the area of thermal ablation. This was successful, and accordingly, the RF electrode was placed safely into the nidus, and ablation was performed in a safe way. This was another case in atypical site, which is in the lateral epicondyle of the humerus, and the challenge here was how to maintain a stable position again of the RF needle into the nidus in the lateral epicondyle of the humerus. In this case, again, we gained access to the lesion using a bone biopsy needle, and if we try to use a coaxial approach, there will be a heavy weight of both needles which may break. So we remove the bone biopsy needle, and then we reintroduce the RF needle only along the same tract into the nidus, and finally this was the final position of the RF tract, and a very small active tip, to 7 millimeter was enough to perform good ablation. This was a case of a very tiny osteoid osteoma in the head of the second metatarsal bone in the foot. The challenge here was how to place the foot in a stable position on the CT table in a patient having general anesthesia or even spinal anesthesia. And this was the final position. We wrapped both legs together and we placed the foot of the patient, both feet all together, and we introduced the bone biopsy needle to gain access to the nidus, and then we removed it and reintroduced the RF electrode with a very small active tip, only 7 millimeter active tip. And as the lesion was very superficial, hydrodissection was used to protect the skin and subcutaneous tissue. Ice cold pack was placed on the patient's skin all over the ablation procedure, and a very small active tip was used to perform safe and effective ablation of this case. This was a case of osteoid osteoma in the acetabulum, as we can see, and all surgeons refused to perform surgery for this case. And also it was challenging concerning the thermal ablation. We have the femoral vessels here, we have the sciatic nerve here, and we have the urinary bladder and rectum on the medial side of the lesion, but also we have a cortical defect that helped us to place the patient in the prone position and to directly introduce the RF electrode directly into the nidus. We used here an electrode with a 10 millimeter active tip, which performed this shape and this size of ablation, which was protective to the medially located bladder and rectum and protective also to the synovium. It was successful. No complications happened. No synovitis or effusion happened in this case. This was another case in the cuneiform bone in the foot. Again, it was very superficial, close to the skin and subcutaneous tissue. We placed the patient in this position. We gained access to the nidus with the bone biopsy needle, and we used an RF electrode with the cursor to maintain the active tip at only 5 millimeter, which was equal to the size of the nidus. Ice cold packs were applied on the patient's skin all over the ablation, and subcutaneous injection of dextrose continuously to protect the skin and subcutaneous tissue, and it was performed safely and effectively. This is a case in the sacrum, very close to the S1 nerve root. The nerve has to be protected using epidural injection of air and dextrose, also subcutaneous injection of air and dextrose, and the thermocouple was used for safe and effective ablation of this case. The active tip was only 7 millimeter, which was equal to the size of the nidus, and the safe ablation was done. This was another case of osteoid osteoma in the scapula. We performed microwave ablation of this case, 3 cycles of 3 watt of microwave ablation at 40 seconds and 2 cycles of 30 watt at 30 seconds. This was the shape and the size of ablation by the end of the procedure. We should put into consideration that the suprascapular nerve is located here. As you can see, the suprascapular nerve is away from the mechanical injury and thermal injury of the needle, and a safe and effective microwave ablation was performed. So the same systematic review we've seen in the first slide has concluded in its conclusion that even for the osteoid osteoma near nerve sites and other atypical sites, the success rate was 91.5% and 97.8%, demonstrating the success of RFA in osteoid osteoma treatment. So in conclusion, thermal ablation is safe and effective in treatment of all cases of osteoid osteomas. We have to be well equipped with the appropriate CT machine and software. We have to be well equipped with the appropriate RF and microwave electrode with good choice of the active tip and also the protocol of ablation. Not all protocols could be applied for all the lesions. And good patient positioning to attain the safest and shortest route should be considered. This was a paper we've published in 2022, talking about, in 2020, I think, yes, talking about the RF ablation of osteoid osteoma in atypical sites in large case series. And thank you.
Thank you, Gamal, for this very nice presentation. I would like to ask you about only for benign bone lesions, osteoid osteoma is ablated, or you can ablate other lesions such as fibrous cortical defects, enchondroma, if causing pain?
We have ablated osteoid osteomas. We have ablated chondroblastomas. Many cases of chondroblastomas. It was very effective. We have ablated inchondroma. We have ablated. We have tried to ablate some aneurysmal bone cysts, but nowadays sclerotherapy has very, very good effect on aneurysmal bone cysts nowadays, and maybe next year we will show the cases we have done sclerotherapy for aneurysmal bone cysts, and also we ablate metastatic bone tumors.
Thank you.
دكتور جمال معلش انا لسه طبعا موري حضرتك الصوره. يعني اولا بشكرك على المحاضره الجميله، وثانيا طبعا ما شاء الله عليك في البون عملت طفره يعني، فبنشكرك على الشغل الجميل ده. في حالات كتير احنا ما نقدرش نستخدم دريل، فبنستخدم بون بايوبسي كيت يعني فور سيفتي عشان برضو نعمل سيريال اندر سي تي ابص وارجع تاني. امبارح تحديدا احنا كنا شغالين اوستيودوستيوما في يعني 9 years old child جنرال انستيزيا في السي 2 روم، ودخلنا بالنيدل بايوبسي لغايه ما وصلنا التارجت لينس ان احنا ندخل فيه الكترود يعني، واحنا راجعين النيدل بقى اتفصلت، يعني الهاندل اتفصلت من الشافت، فالشافت بقى ريتيند. فطبعا كانت مشكله بالنسبه لنا ان احنا نموف العيان لغايه جراحه العظام والكلام ده. فالدريل از ماست ولا في يعني ريجنز معينه I have to use the drill and no يعني chance for bone biopsy. We always using bone biopsy kit.
اوكي طيب انا هقول لحضرتك حاجه، انا هقولها برضو عشان لو حد برضو معانا بيبدا يعني يشتغل البروسيجر ده. هقوله على مفاجاه كمان. ما بقيتش اشتغل حالات اوستيويد اوستيوما ابليشن او بون تيومر ابليشن في مكان ما فيهوش دريل او ما يكونش الدريل معايا.
لو سباينال
all cases لازم يبقى في دريل معايا، حتى لو كيس سوبرفيشال، حتى لو كيس فيري سوبرفيشال لازم يبقى في ابقى باك اب ان في دريل موجود معايا. ليه؟ لانه ممكن يحصل انسيدنس فور وات ايفر ريزن ان يحصل يعني بريكنج للنيدل للبون بايوبسي نيدل، وفي الحاله دي البون بايوبسي نيدل مش هتطلع غير بدريل، لازم هلف عليها الدريل والفه بالعكس واطلعه، حتى لو انا مش هستخدم دريل في بدايه الحاله خالص، بس عشان ابقى مطمن لازم يبقى معايا دريل. طيب المفاجاه الثانيه، ما بشتغلش حالات دلوقتي بون ابليشن الا لما يكون في جهاز الترا ساوند معايا. الترا ساوند ازاي؟ طب انا بشتغل سي تي جايدد. الحالات اللي شفناها هنا اللي كانت في الميدل فينجر وحالات الفوت وحالات التوز والدورسم اوف ذا فوت، انا بستخدم جهاز الالترا ساوند عشان اعمل بروتكشن للدورسال سبيدس ارتري وللتندنز، وساعات ممكن ادخل الترا ساوند جايدد بعيد عن الارتري والفين والتندون، بس احط الابره البون على اول الليجن وخلاص، بس جهاز الالترا ساوند بعد وابدا بقى اعمل الدريلنج بتاعي. فبالتالي النصيحه الاساسيه زي ما قلنا هنا في الكونكلوجن، ويل ايكويبت. انا شغال معايا بون دريل موجود حتى لو مش هستخدمه، بس موجود معايا ان كيس، وممكن جهاز الالترا ساوند كمان هبقى محتاجه في نفس اليونت اللي انا فيها.
تمام شكرا.
شكرا دكتور جمال. Now we'll shift for the second session. دكتور مصطفى فريد